So I think we're going to go ahead and go into a discussion about reproductive and sexual health. You'll see that it is recording here. When we get to the end and do a Q&A section, I'll stop the recording so that people can feel free to ask their own questions and know that those are not being recorded. So I'll let our two analysts who are going to be in conversation together go ahead and introduce themselves.
Want to go ahead, Libby?
I'm muted. Hi, everyone. My name is Libby Dotson, and I'm a research associate in the Center for Global Women's Health Technologies, where my work focuses on the public health implementation strategies of new technologies for reproductive cancer screening.
Thank you. I am Lindsay Parker. I am a student development coordinator in Do Well in the Wellness Center, and I am primarily a healthy relationships and sexual health educator on campus. So I talk with undergrads mostly, but also graduate and professional students about these very topics that we saw discussed in this documentary. So I'm glad to be here in conversation with each of you and with Libby, and just to have some meaningful dialogue. So thanks again for being here.
Great. Well, we can go ahead and dive into the topics we have for today. We're going to be going over women's reproductive anatomy. We're going to talk about HPV, navigating difficult reproductive conversations, and then also touching on global disparities in accessing reproductive health services. Great. Well, our first topic is women's health anatomy. And while this may seem very middle or high school PE class-esque, there is actually a survey that was recently distributed among 1,000 women that identified that nearly 50% of those women had trouble identifying even one of these anatomical parts on a medical diagram like the ones you see on the screen. And so I think to really understand and be able to proactively engage in your reproductive health, it's super important that you feel comfortable with your own anatomy and are able to have some words to describe the different parts of your anatomy. And so first, we have the vaginal canal, which is what we'll be discussing first. As you see on this right diagram, it's the bottommost portion. And while we all know what this organ is and where it's located, most of us do, a lot of us don't realize that it also serves a really important function for our menstrual cycle. And so it provides a pathway for blood as well as mucus and tissue that helps, regulate our pH balance and also keeps us healthy. And as you know, it's also a passage for childbirth. And that leads me into the next anatomical part we want to talk about, which is the cervix. And if you look here on this right diagram, the red part on the bottom is your vaginal canal. And right above it, this area is the cervix. And a lot of us do not know what the cervix was. I didn't know what it was until I actually dove into this very specific research on cervical cancer. And the cervix is a small donut-shaped organ that has a very, very small, only a few millimeters wide os in the center that serves as a passageway between your uterine canal and your vaginal canal. And it's actually the passageway for fertilization. It's also a location for mucus that fights bacteria from getting further into your reproductive health tract. And that tiny little, in the middle of the donut-shaped cervix, that tiny little few millimeter os is actually the passageway for childbirth. And so that os dilates. It's what you hear when women are saying they're dilating to 4, 5, 6 centimeters. It's that tiny little circular entrance that's dilating. And so the cervix not only protects us, but it also is a passageway for life. And then other parts, the fallopian tubes, which transport transport the ova from the ovary to the uterus each month during your cycle. And then the ovaries and follicles, the follicles are a fluid sac containing immature eggs. And it always, in any given time of the month, it can contain between 8 to 10. And then during ovulation, during your menstrual cycle, a mature egg is released from this follicle. And that is when you could be ready for fertilization. And so I will pause for a second for any questions, and for Lindsay for you to jump in with your information.
That was fantastic, Libby. I work a lot, like I said earlier, with students, having conversations about sex and relationships. And one thing that I really want to point out when we're talking about anatomy is how many times in your life have you heard someone in your family or someone on a TV show or in a movie refer to these anatomical parts by a name that wasn't given to them via science, right? Like a little nickname for the vagina. Those were embedded early on in the lives of girls, of boys, of non-binary folks. And we're talking more about that. And I think that's really critical to think about, because for me, as we're sort of paving the way for the rest of our conversation, these things show up a lot in sex and relationships when you have these really internalized feelings about the parts of your body that in many ways define you or guide your life. And we talk a lot about communication, in particular with sex and relationships. But something I often find myself wondering, asking students about and talking with students about is, if we can't communicate the very essence of some of this anatomical and scientific piece, how can we be expected to have even more intimate conversations with a partners, our providers, even ourselves in reflection? So I think this is a really key moment to think about, for me at least, how critical the interdisciplinary nature of this work is. This is truly the meeting of so many topics. And so I see this anatomy as very foundational. So thanks so much, Libby. And again, if folks have questions.
Absolutely. Thank you, Lindsay. So, as we're looking at this slide about the cervix, and we just watched the documentary that was focusing on a case study of cervical cancer and new medical technologies, we want to start exploring the human papillomavirus. So some of you may have heard of HPV. You may have heard it in the context of a vaccine or otherwise. And so first, we just want to cover what HPV is and its relation to the cervix and cervical cancer. And so HPV is a sexually transmitted infection, and certain subtypes of HPV directly lead to reproductive cancers, most notably of which cervical cancer. And STIs are traditionally quite taboo in conversation, but I think what's really important to emphasize is that HPV is extremely common. So common that nearly all men and women will contract some form of the virus during their lifetime. And at any given time, about 80 million Americans are infected with HPV. And a lot of the times, HPV infections clear up on their own within 2 years, and you may not even be symptomatic. That's about 9 of the 10 different subtypes clear up completely on their own. But sometimes it can last longer, and 1 in 10 times that someone contracts HPV, it does lead to certain types of cancers, namely cervical cancer. And it actually does cause 36,000 cancers in the US each year. But what's great is that we have a vaccine that prevents HPV, and also by doing that prevents the incidence of these different reproductive cancers. This vaccine was just developed, got FDA clearance in 2006, and was on the market in 2007. So if you're of university age now, it should have been something that your doctor may have recommended between the ages of 11 and 14. 16. And the reason they recommend it so young is not because you're sexually active at that time. It's because the vaccine has the most efficacy when it's given before either a boy or a girl becomes sexually active. So that's why they really want to catch you in your early teen years. And then you can also still get the vaccine up to the age of 29, which leads me into the next section about dispelling common myths. So the HPV vaccine has been a site of some controversy over the past 15 years of its implementation because for a variety of reasons. Some of it is, related to safety. Parents have concerns about safety. Other times it's parents don't understand the necessity. They have a lack of knowledge about what the vaccine does. And we found that there's actually a large gap in doctors fully giving the education to parents that they need to make that decision. And then as well as religious and cultural beliefs, it's kind of scary for a parent to be asked by a provider to give their 11-year-old a vaccine for a sexually transmitted infection. And so all of these reasons are, valid concerns parents have. And, my own mom did not allow me to get vaccinated at the required age because of her religious beliefs. And that's okay. That wasn't, her fault. It was the lack of education that was given to her about why I needed that vaccine. And so, the vaccine, dispelling one myth, the vaccine is not safe. Over 270 million doses have been distributed since 2006. Only teenagers should get the vaccine is another myth. The vaccine, you can get it at as early as 9. It's most effective by age 13, but you can be vaccinated until you're 29. So if you're not yet vaccinated, that's absolutely okay. And you can seek, a provider at Duke and start that conversation with them. And then something else that's important to know is there's a big myth going around that it's not helpful in preventing cervical cancer, but clinical studies have shown that it's almost 100% effective in preventing the subtype strains of HPV 16, 18 that cause cervical lesions. And so I'll just give a little more information. I'm going to turn it over to Lindsay, but I just want to emphasize that it's, okay if your parents did not facilitate you getting that vaccine, and you can still get the vaccine. If you're unsure, usually when you come to the university, you have to submit your vaccine record, and you can log into Duke MyChart and see. And then also, many states allow teens less than 18 years old to still get the HPV vaccine without parental consent. North Carolina is one of those states. This is something you have to be careful about, working with your parents and their beliefs, but you can even go to your local pharmacy and get the doses of that vaccine. If you're under 18, even if you're university age 18 to 22, you can get it at the pharmacy as well. So we encourage you to review your vaccine records, schedule an appointment with the provider, and initiate that conversation if you're unsure.
Yes to everything Libby just said. Talking to your provider about this is important, but we also know it's not always easy. So maybe it's a case of if you're not feeling super comfortable, finding a new provider, asking friends for recommendations, reading reviews online. Something else that I want to point out is that thinking about and talking about the HPV vaccine is a key part of comprehensive sexual health education, but it's not all about sexual health education, right? Those things can coexist. And Libby made the point, which I think is so sage in that her mom wasn't comfortable with that. While her mom isn't to blame, we think about she's a part of this system in which we've been shamed or feel uncomfortable to talk about certain things. So that's where we really, when we're talking about comprehensive sex ed, that's why we talk about the importance of talking about these things really early on with young children, talking about them with providers, using correct terminology and language, staying away from fear-based tactics. So much of the narrative around getting the vaccine and not getting the vaccine is fear-based. And what does that mean? And how can we re-envision and recreate like a health communications perspective using good public health information, thinking about the implications of so many other people and groups and places doing the work? That's huge. So, even thinking about like the stigma around STI testing, as we reduce stigma around STI testing, that reduces stigma in this way. So that's where I'd really encourage us to think critically about this continuum and how how just interconnected it all is. I think about when we had STI testing happening on campus. We still have it, but we had some pop-up testing events prior to COVID-19. And people would often ask me how many people got tested. The number of people getting tested is important, but what was really important to me too was the fact that people were coming, knowing that this event was happening. They were kind of coming to a common space, seeing each other get tested, not being in the room when each other was getting tested, but seeing like, oh, so and so signed up for, and just seeing people in that space. I think that went a long way in thinking about reducing stigma, and perhaps that matters a little bit more than we once thought, right? And I think it's really similar when we think about HPV and the language around both HPV and the HPV vaccine.
Great, thank you, Lindsay. So before we transition into talking about reproductive health disparities, we just want to emphasize that the CDC recommends that you start seeing a gynecologist, around at age 21. There's evidence suggesting that, it's even better to initiate a relationship with a provider earlier. So at 18, 19, 20, so that you can start, understanding and being proactive about your health, start getting STI testing, initiating those conversations about the HPV vaccine. But the CDC does recommend a Pap test, which is the standard test to see if there's cervical abnormalities or cervical lesions or cancer. And just want to emphasize when you hear Pap test, the reason for getting a Pap test is to test for these different reproductive cancers. And something important to note about cervical cancer is, and this leads into the discussion about disparities. Cervical cancer is one of the only cancers that scientists know of we know the central causal agent, HPV strain 16 to 18. We know how to prevent it through vaccine or regular screening tests like the Pap smear. And we also know how to treat it within its first 10 to 15 years. And so while it seems like this would be an easy public health problem to tackle in the sense of, we know the cause, we know, it's preventable, and we know the treatment, there's actually large disparities in the burden, incidence, and prevalence of cervical cancer globally, but starkly here in the US. And the predictors of access to these screening services are on the lines of education level, geographic region, your insurance coverage, your religious beliefs. One very strong indicator is actually your mother's knowledge and education about health and childhood family situation, sexual intercourse experience, and previous gynecological diagnoses. So everything I just mentioned are predictors of women's access and uptake or use of cervical cancer screening and other reproductive screening services offered in the US. But because there's so much stigma, there's so much shame which are social barriers. There's structural barriers, which is, you know, gynecologists in some rural parts of the US are few and far between. So you may have to drive 30 minutes versus if you live here in Durham, you drive down the road, chances are there's an OB-GYN. And all of these things compile to still lead to some parts of the US having prevalence of cervical cancer as high as 19% in some regions of Alabama, and mortality 70 to 80%. So 70 to 80% of the women who contract cervical cancer end up dying. And that really is a shame here in the US with all of our access to technology and healthcare. And so we just want to start, you know, talking about these disparities and bringing them to your attention, so that we can collectively, through destigmatizing, through conversation, start educating others and sort of bringing attention to these issues around cervical cancer.
And I'll just quickly add to, you know, these disparities don't end here, particularly in thinking about Black women and maternal mortality rates, right? Like these issues tend to pile on top of each other. So the inequities just continue to be layered over time. And I think that is a really, really key piece of this discussion too, and thinking about the disparities more broadly.
And we've included a few articles and resources we have that we can share, that explore all of the topics we've discussed, but also this issue if you want to learn more about these disparities. There's some really awesome podcasts here. I love the V Word. Saludable Latina is amazing. So I'd encourage us all to start interacting with these resources, building a community around our sexual and reproductive health.
I also, and this isn't a little bit of an aside, but related, Jen Gunter is fantastic. Her Twitter, she's recently really pushed back to companies like Vagisil for kind of shaping the narrative that is rooted in stereotypes that are designed to make us feel confused or misunderstood or ashamed of our own anatomy, and being really critical consumers is important. And I think she does an excellent job. I also love the V Word, so do check some of these out because I think you'll find them really fascinating and insightful.
Great. Well, that concludes our panel presentation today. So I'll turn it back over